Hello, hello, hello. Good morning, students. Good morning. Am I visible to all? Am I audible to all? Welcome to our marathon. We'll just from where we are streaming, there will be some lag. We'll just verify whether we are live or not, and then we'll begin the session. Okay. So just are we live? Yes, I think we are live. Yes, I think we are live. And is the chat box also working properly fine? Yes, so I think so. Is the audio video all clear? Yeah, good morning Manjulata, good morning Imran Siddiqui. Yes, so I think the audio, video, everything is clear, and let us begin our session. It's going to be a very useful session for the upcoming FMGE, and even if your exam is NEET PG, we're going to discuss lots of MCQs. It's a marathon, don't we will try to keep it very lively and easy. Just a couple of things before we begin. Okay, so all of you, and I'll just give you the whole thing in a minute. Just quickly settle down, all of you. Yes, so all of you are aware of the Unacademy NEET PG, and this is a iconic subscription which is being offered, where you get plus classes, all the very good live lectures along with the recorded content also by the best teachers, and very good notes, and also mentoring sessions. Okay, and the code used is mentor, MENTOR. Please use the code mentor to get the discount and the at the price. And you can see that there are lots of discounts, and you can choose 6 months, 9 months, 12 months package as per your convenience. Okay, so the code is mentor, MENTOR, to get the discounts. Okay, and similarly this is a very nice offer. The code remains the same, mentor, MENTOR, where you get 9 months, you get 2 months free. Okay, so again you get plus lectures, plus vitals, which is the studio recorded, completely recorded set of lectures, and notes and mentoring session. So this is valid till 23rd July, and as I said, the code is mentor. Okay, so with this couple of information, and of course as I told you, vitals you should definitely check out. They are super pre-recorded lectures which are really going to help you. Lots of students have already taken the subscription, and the advantage is, all of you know, anytime, anywhere, best teachers, question bank, test series, notes, and any device of your choice. Okay, so what is the basically, so download the Unacademy app and don't forget to use the code mentor. Okay, now what is the plan for the day, okay, or for this session? Okay, so it's a marathon. It's almost going to be like 2.5 hours, but we have tried. I will be discussing, absolutely, these are absolutely high yield, absolutely must know MCQs, which are going to come, or very likely to be coming, in the FMGE exam after 15 days time. Okay, I will ensure you that we will be discussing at least, like, even if I go for 2 to 3 minutes per MCQ, or even more time, more than 40-50 MCQs are going to discuss, both gynec and obstetrics, in the next 2 hours time, 2.5 hours time. Okay, so it's a marathon for OBGYN, and then you're almost completely prepared. So I have also selected the high yield topics. I had given you the list of high yield topics. So in gynecology, infertility questions will come. I'm just giving you a recap. In gynec, you will get questions of infertility, contraception, menorrhagia, primary amenorrhea. All these topics MCQs are there, and even cervical cancer. So all these topics MCQs will be discussed in the next 1 hour time. And of course obstetrics, a mix, gynec, and obstetrics also, trisomy 21 detection, test for fetal well-being, NST-BPP, ectopic pregnancy, pre-eclampsia, heart disease in pregnancy, diabetes in pregnancy. All these MCQs we have covered for all of you in this next 2 hours time. So please, these are where APH. Okay, so very important, PPH, forceps vacuum. So all the most important topics, the hot topics, what you say, all these are going to be covered in the next 2 hours. Okay, rules remain the same. Please feel free to ask questions, please answer questions, and type in the chat box, and let's make it a lively session. Okay, With this, let us begin. The first thing, the earliest ultrasonography sign of a pregnancy is 1, 2, 3, 4 or A, B, C, D. Anybody? When there is pregnancy, what is the first sign? Earliest sign or the first sign on pregnancy? And what is it and which do you get? Okay, no Chanda question saying, hey, chalo, all of you please participate. I want all of you to answer. Mishab Sheikh 2. Okay, anybody quickly, once 5-6 students give the answer, I'll tell the answer. Okay, yes. Okay, yes, very good Manjula Tapan, all of. Okay, so please understand that whenever the patient is pregnant in early pregnancy, transvaginal sonography is preferred. Transabdominal sonography picks up the same thing after 1 week, because uterus is a pelvic organ, so in first trimester always prefer to go for a transvaginal sonography. Whenever the lady is pregnant, the first thing what I see is the gestational sac. The gestational sac, the true sac or the regular or the normal sac or the actual sac is proper regular. Okay, best sign, beta will discuss. There's nothing like a best sign. Will tell you what it is. Okay, so okay, Manjula, give me. Okay, so proper, the gestational sac is regular. It has to be regular. It can't be very irregular. Irregular is not a good sign. It has to be regular, and it has got a thick echogenic ring around it called as a good decidual reaction or a double decidual sign. And this is always the first sign of pregnancy on ultrasonography. So well defined, circular with a thick echogenic ring and a double decidual sign. Okay, that is the gestational sac, is always the first sign. Anybody after that, what comes next you get is the yolk sac. Okay, second sign. Within this, it's like circle within a circle. Inside this, after few days you will see another circle. Okay, so can anybody tell me the outer circle is the gestational sac? This inner circle which I have drawn is the very good, the yolk sac. And then comes the baby, the fetal pole which is attached to the yolk sac. Okay, so then comes the fetal pole. Okay, so if you see in order, this is the sequence, this is the second and third, and somebody marked free fluid. But a free fluid in a pouch of Douglas, can anybody tell me is a sign of what? Free fluid is a sign of what? Free fluid is a sign of, free fluid is a sign of, free fluid is a sign of ovulation, because around the mid cycle, when the follicle will rupture, inside the follicle is the egg. No, yeah, we'll discuss that. Okay, so yes, so free fluid could also be blood. It's not always ectopic. Yes, okay, so it could also be in when this egg will, when the follicle will rupture, the fimbria will pick up the egg, so this follicle will collapse. So all the follicular fluid. So free fluid around mid cycle. Okay, if around the middle of the cycle you see 14-15 day free fluid, it is a sign of ovulation. Yes, this free fluid, if it is blood, it could be a sign of ectopic. Okay, that is basically, and it could also be a sign of any ascites or fluid, or yes, very good Franca, I was going to tell you pelvic inflammatory diseases, so it could be inflammatory fluid. Okay, so PID, ectopic, but physiologically month after month if you see, always free fluid will be seen in the patient. So free fluid, all free fluids are not abnormal. Free fluid, if you see on the 13th 14th day of the cycle, it is a sign of ovulation. The question is about pregnancy, and that's why the answer is not free fluid, because free fluid is a sign of ovulation. There's a difference between ovulation and pregnancy. Every ovulation will not lead to pregnancy. Okay, so gestational sac is the free. Now somebody, it's not about the best sign, we want to confirm that what is surely a sign of live pregnancy in the presence of fetal cardiac activity. Fetal cardiac activity is surely telling me that it is a live pregnancy. So till the time I see the baby's heartbeat, I cannot comment, because there are cases where yes sir, the gestational sac is seen, yolk sac is seen, even fetal pole comes but the heartbeat does not start. Okay, is it clear? So somebody was asking, so what is the best sign? I would not say the best sign, but a confirmatory sign of live pregnancy, that is fetal cardiac activity, and that can be earliest detected only by transvaginal sonography. Okay, so transvaginal sonography in the whole world, if they tell you which is the investigation, okay, which is the investigation which in the whole world can tell you it is a live pregnancy, and if you have options transvaginal sonography, transabdominal sonography, your Doppler machine, okay, the fetal Doppler, or even the stethoscope, anybody, what is the answer? Yes, transvaginal will tell us earliest, yes, around 6 weeks. Yes, middle smudge is a pain. Okay, then transabdominal, the Doppler picks up sonograph heartbeat at around 10 weeks, and stethoscope, all of you know, is later. Stethoscope only when the pregnancy is around 18-20 weeks. Stethoscope can pick up heartbeat at around 18 weeks time. Okay, so earliest diagnosis of live pregnancy. So again, see three MCQs discussed. Okay, so gestational sac, yolk sac, then comes this as the fetal pole. Fetal pole matlab that the baby has come in, and inside the pole then we see the fetal cardiac activity. Okay, so transvaginal, yes, excellent, all of you. Okay, moving on. Yes, again a very hot topic, always you get the drop in fetal heart rate associated with, so these are the three types of deceleration. So on a NST or on a basically CTG, cardiotocography, on cardiotocography, the drop in fetal heart rate with placental insufficiency is which one? Okay, or the one which indicates fetal distress, or also fetal hypoxia, all mean the same thing. Very good, not three. Okay, yes. Okay, so can anybody tell me what are these? Yes, so can anybody tell me, this can also come as a match the column. This MCQ can also come as a match the column, where on one side you have the decelerations and here you have the reason why there is the deceleration. So anybody, three types of deceleration: early, late, and variable. So see, again with one MCQ we are discussing three MCQs. Every MCQ you will learn three more MCQs. So by the end of this 2 hours, more than 400-500 MCQs will be discussed. Okay, yes. So can anybody tell me? Okay, so when do we get, and what is the meaning of this early, variable, and late? That is when you actually become a gynec, we will teach you. Right now don't bother too much, is in relation to the contractions, all that. No beta. Okay, early is not in cord compression. Okay, Chanda and Pranav. Okay, so early deceleration is because of head compression, when the fetal head touches the pelvic floor. So head early deceleration is considered like normal. It's not normal, but like many patients, almost all babies, when the fetal head touches the pelvic floor, you would get it. Late is the one which is actually dangerous, because this tells me there is fetal distress, or your basically uteroplacental insufficiency, UPI. Okay, acute, if there's acute uteroplacental insufficiency, you get this. And variable is because of cord compression. Is this clear to all of you? Cord compression. No beta, variable is not in RH incomplete parva. Beta, you are doing wrong. Beta, that is your sinusoidal pattern. Okay, so cord compression. Okay, yes, so fetal hypoxia, very good. So drop in fetal heart rate, either if they tell you fetal hypoxia or fetal distress or placental insufficiency, all mean the same thing. Answer is late deceleration. Early is head compression and variable is cord compression. Okay, is this understood to all of you? And by the way, very difficult MCQ. Yes, so all of you correct, those who said option B or number 2. Prolonged deceleration. This is again, they are not going to ask you, but any deceleration which is more than 2 minutes. That means all of you look over here, this is the baseline, and the heart rate starts to drop down, and then it comes back to normal after 2 minutes. Okay, so any deceleration which is lasting more than 2 minutes is called as prolonged deceleration. So this you get it in cases of like when there's severe, like if the mother gets eclamptic convulsion. okay, or if there is cord prolapse or abruption, basically any severe fetal distress, okay. So any deceleration lasting for more than 2 minutes is called, like if here the deceleration happens until here it is going to be more than 2 minutes, we call this as a prolonged deceleration, okay. They are not going to ask you this, but only to complete the topic, okay. Moving on to the next question, very basic for FMG, you should not make a mistake. The main cause of maternal mortality in developing countries, by developing you know still India, Pakistan, Bangladesh, Sri Lanka, all the developing countries. Anybody, what is the answer? Very okay, 2 3 C, okay, very good. So no, but the unsafe abortions are becoming very rare now. Similarly, obstructed labor is also becoming very rare. Very good. This hemorrhage is mainly postpartum hemorrhage, but antepartum hemorrhage can also contribute. So hemorrhage is the most common cause in developing countries. But again, yes, very good, Gango. And anemia will indirectly worsen. So anemia is the indirect. Very good. And just by the way, instead of developing countries, if they make it as developed country, in foreign countries, USA, UK, France, then remember it is the hypertensive disorders, that is your preeclampsia, eclampsia, okay. Anemia beta is indirect cause, okay Manjulata. Anemia will not directly kill the person. Anemia is, yes, important, but anemia is the most common indirect cause of maternal mortality. So when you look at the PSM teacher will teach you, when you look at the maternal mortality, there's something called as direct causes, so indirect causes. So hemorrhage is the direct cause. Anemia is definitely going to worsen the patient's capacity to tolerate the blood loss, and therefore anemia is the most common indirect, okay. Just by the way, general opinion, we almost this thin is okay, this pen tip thin is okay. If you want me to make it like a thicker pen, or this is okay, because thick one will then becomes too thick, okay. So is this thin one okay, or you want me to write a thicker one, okay, whatever, tell me. Yeah, okay, is it clear to all of you? So please keep this in mind. The main cause of mortality, nothing more to discuss over here. Questions will come in, yes, perfect, thank you, okay. Nothing will come more in this, and of course PPH APH questions we are going to we are going to discuss in the upcoming session, upcoming now in the next hour, okay. Yes, so anemia most common indirect cause, okay. Moving on, cervical ripening. Now when I want to induce labor, cervical ripening, which of the following drug do I use and which one? Cervical ripening. Okay, Rafiq is saying option 1, A, B, D, okay. Okay, Pranos, okay. Yes, so please pay attention. We have got different types of drugs. We should know about them in detail. Please understand methergin. Out of this, methergin and PGF2 alpha, they will cause a strong contraction of both upper and lower uterine segment together, will cause the upper segment also to contract and lower segment also to contract. So methergin and PGF2 alpha we can never use while the baby is inside the mother. If the whole pregnancy is there, if the baby is inside the mother, and if I give methergin or PGF2 alpha, it will cause calamity, okay, it will cause calamity. It can cause rupture, uterus, baby dead, mother dead. You should be put to jail. So what am I saying is that only once the baby is out, PGF2 alpha and methergin can be used only for one and only one drug, which is for PPH, okay, for prevention and treatment of postpartum hemorrhage. So PGF2 alpha and methergin have got only one use, which is your PPS. Yes, by the way, PGF2 alpha is also called as carboprost, okay. So you can have to keep this in mind, that what is PGE1 called as analog, what is PGE2 called as, and what is PGF2 alpha called as. So PGE1 is what, anybody? PGE1 is what? Yes, PGE1 is misoprostol. Beta Chanda, PGE2 correct is dinoprostone. Okay, so dinoprostone is PGE2 and PGF2 alpha is what I told you, carboprostone. Okay, so not mifepristone, Pranav. Yeah, mifepristone is different. Mifepristone is RU486. Mifepristone is not your prostaglandin. Okay, mifepristone is different. Mifi is anti-progesterogenic drug. We also call it as RU486. Okay, that is for MT. We will again discuss that also. Don't worry. Okay. Yes, so PGE1 mesoprostol, dinoprostone, carboprost. इसमें से F2 alpha and methergine is only used for PPH, postpartum hemorrhage. Okay, postpartum hemorrhage. Anybody? PGE2 is the answer. Cervical ripening, when the cervix is tightly shut and I want to induce somebody's labor, induction of labor, then I use PGE2. By the way, if you know the brand name, anybody brand name you all are not supposed to know, but PGE2 comes in the form of a gel which you use in the labor ward. What is the brand name of the gel? Anybody? What is the brand name of the gel? Yes, very good. It is Cerviprime. Okay, so as the name suggests, cervical priming. Cervical priming or ripening is PGE2. Okay, so PGE2 is the answer to this very, very important MCQ. You'll remember me on the day of the exam is my guarantee. Okay, F2 alpha is carboprost, which is only used for PPH. Okay, yes, methergine is also only used for PPH. Okay, yes. Next, moving on to the next question, and that is very all are components of Manning's biophysical profile except. So what is this BPP, biophysical profile? What is it? What is this test done for? What? Two, one. Why is 2 the answer? Yes. So all of you, very good, those who have heard me before. Okay, so please keep in mind. Yes, very good. So BPP is a test for fetal well-being. Okay, we want to know how the baby is inside the mother. So all the high-risk pregnancies, pre-eclampsia, diabetes, all that. Okay, so fetal well-being के लिए हम करते हैं BPP. Can anybody tell me BPP has got how many components and what is the maximum score of BPP possible? If they ask you, maximum score of BPP is possible 6, 8, 10, 12, 13, 7, 9, 11, 1000. What's the answer? Very good, excellent. So sir, totally there are 5 components and each is given a score of 2 or 0. So max possible is always 10. It could be 2, 4, 6, 8, 10. Please understand, it can never be a odd number. It can never be 9, 11, 7 and cannot be 12, 13, 1000. Okay, is it clear? Yes, all of you. So yes, 8 to 10 is considered normal. Okay, so now what is the answer? The answer is fetal kick count. And why? Why is fetal kick count the answer? Why is fetal kick count the answer? Because, don't get confused. Can anybody tell me, in this fetal kick count, who will count the baby's movements? Mother, okay, doctor, husband, matlab father, neighbor. Chalo, A, B, C, D. Who will count in fetal kick count? Who counts the movements? Mother, doctor or intern, the father or the neighbor? Yes. So in this fetal kick count, the mother is counting the fetal movements. Very good. But can anybody tell me, when I do BPP, who counts the fetal movement and how is the BPP done? So this is a very, very important thing. Many students even after internship don't know this point. Okay, please keep in mind that in BPP is a combination of NST plus ultrasonography. NST is done using the NST machine, and ultrasonography has to be done for 30 minutes. Very good. So it is over here the radiologist or the doctor or the sonologist. So NST is the first component. Then we look at fetal tone, fetal movements. So that is the answer. Fetal movements, fetal breathing movements. I'm writing BM. Okay, and liquor pocket. There should be at least one pocket. So one pocket liquor. Very good, Chanda. NST is like an indication of acute stress, and AFI is an indicator of your chronic stress, AFI tone, all that. Okay, so liquor pocket, at least there should be one liquor pocket of at least 2 by 2 centimeter. Okay, at least there should be one liquor pocket of 2 centimeter in two perpendicular planes. Okay, so if all this is normal, so here in this the fetal movement is counted by the sonologist or the radiologist, rightly told by all of you, and therefore this is the answer. It's a fetal kick count is not a part of BPP. Yes, it could have been fetal movements. This question came in the recent exam and many students got confused. Fetal movements is a part. So NST, breathing movement, fetal tone, fetal movements. Okay, so fetal kick count is just a very like a crude. You can tell the mother to keep a movement fetal kick count chart at home. Okay, so fetal kick count is mother counting the fetal movement. That is different from this fetal movement which is a part of BPP. Okay, yes, I think that's absolutely crystal clear. Let's not discuss. Okay, yes, so this is, and anybody, what is modified BPP? This also is asked to you in the exam. Modified BPP, it is rather than doing all the 5 components, we do only 2. Yes, NST plus AFI. When I do NST plus AFI, which is amniotic fluid index, that combination is called as modified BPP. Yes, okay. Now anybody, a clinical case, I want first all of you to make the diagnosis. What is your diagnosis? Because clinical cases have also started coming in the FMGE exam and you will get it. Please read the question correctly. Please type in the chat box the diagnosis first. I don't want the answer. I don't want the answer. I want the diagnosis. That I have got a patient who is in labor with uterine contractions. Okay. PV pay 3 centimeter dilated. No, but IUFD is understood. Baby is IUFD. What does this mean? That is okay. IUFD, everybody I know. I don't want to do that. Per abdomen, lower pole empty, and head on the right side. Matlab, what is this? This is what I want. IUFD, I know it's written over there. IUFD is not your diagnosis. What is the main diagnosis? Then why you are doing LSCS? Everybody told LSCS is the answer. Why you are doing LSCS if it's IUFD? Baby is dead. Why are you? Yes, very good, Chanda Chandani. Sorry, I was reading as Chanda. Chandani Keshwani, perfectly. Dr. Humble, very good. This is a transverse lie. Please understand, when the baby is, yes, very good, Dr. Upadhyay. When the baby is in transverse lie, that is the time when the lower pole is empty. That is the clue, and they have told you head. So head could be on the mother's right side, head on the right side. That means if this is the mother's right side, this is the mother's left side, here is the head. So head on the right hand side and lower pole empty. This is perfectly a transverse lie. Now in transverse lie, if the patient is already in labor, anybody, why not wait and watch? I should have given one more option, wait and watch, as the answer. Anybody? Why not? Yes, induction is contraindicated, agreed, but why? If it's wait and watch is the answer, what is the answer now? Wait and watch is also there. Baby is already dead. Yes, baby will die, but baby here is already dead. Baby here is already dead. Yes, so when the transverse lie is there, the main danger is as the cervix will open up, there's a very high risk of cord prolapse and the baby can die. But here now already the baby is dead. Okay, this question, my question is, here the baby is already dead. I want to make the MCQ tougher and I want to add also wait and watch in the option. Now tell me the answer. So we have got lower pole empty, head on right side. This gives us the diagnosis as transverse lie with, and of course baby is unfortunately dead. Chalo, tell me, why not wait and watch? Sepsis, okay, why should there be sepsis? So point number 1, sir, there is no mechanism of labor. There is no mechanism of labor in transverse lie. You can see baby is completely like this transverse, and the maternal pelvis, or mother ka long axis is like this. So both of them are at right angles. The vaginal delivery is not possible only. Is it clear? Yes. What maternal complication? So the uterus will keep on contracting, prolonged labor, obstructed labor. There could be even rupture uterus, but the baby will not come out. Okay, so there is no mechanism of labor if you wait and watch. Therefore you don't wait and watch further, because if you wait, it would lead to prolonged and obstructed labor, and then ultimately it would lead to, yes, uterine rupture, but still the baby will not come out. Therefore, if the baby is alive, if they tell you fetal heart rate is 150 per minute, all the more reason to do LSCS to save the baby, because she is already in labor, there are already contractions 3 centimeter. Moment the membranes will rupture, rightly told by all of you, very high risk of cord prolapse in transverse lie. Okay, but even if the question is IUFD, okay, IUFD hai, still with IUFD also the answer is LSCS only. Why? Because this internal podalic version very dangerous. You are putting the hand inside the uterus and rotating the baby. That is going to again cause very high risk of rupture uterus. So it is never ever, almost never done in modern day obstetrics. And all this is what my students know. What do I say this? Outdated kachra dustbin. Kachra dustbin matlab never to be done. Okay, evisceration, craniotomy, decapitation, never. Even it was thought to be done in dead babies, that you will go inside the uterus and you cut the baby into pieces, टुकड़ा करके baby को निकालेंगे बाहर. All that please don't do, because you can cause complication. So remember student, these are called as destructive operations. So all of you will make a note or write down destructive operations. Okay, in modern day obstetrics, destructive operations are never to be done. Is this understood to all of you? So never ever in your question paper will you ever mark this decapitation, craniotomy, evisceration as an answer. Yes, can I get 5 thumbs up? Then I can proceed further. So all this is never to be done. So sir, if the baby is alive, I do LSCS to save the baby. Here sir, but baby is dead, still I will do LSCS now for maternal safety. Now why are we doing LSCS? For maternal safety. Now for maternal indication, because there is no mechanism of labor. There is no mechanism of labor in transverse lie, and if you wait, it's going to be prolonged labor, obstructed labor and rupture uterus. Yes. Excellent, all of you. Yes. Okay. Again, a similar question. In which of the following out of the four is a vaginal delivery possible? Yes, everybody. Yes, very good. So, sir, when we are looking at face presentation, in face presentation, you get the baby's eyes, nose, mouth, mela. We discuss all this in our detailed plus classes in detail. So, sir, when the mentum is towards the pubic symphysis only, that means only in mento anterior face can a vaginal delivery take place. Can anybody tell me what is the problem in brow? Brow and mento posterior face, again there is no mechanism of labor. There is no mechanism of labor, and therefore you are not supposed to, matlab there is no, it's not possible, there is no mechanism of labor in mento posterior face and brow. Okay, is it understood to all of you? Okay, why? Because can anybody tell me, this has also been asked in the entrance exam, what is the engaging diameter in brow? In brow presentation, what is the engaging diameter, or what is the diameter of the fetal head? So the diameter of the fetal head is mento vertical, which is 14 centimeter. Okay, yes. So very good. So brow में there is no labor possible, and mento posterior face also, it's a very big sternobregmatic, so it cannot negotiate the pelvis. Very good. So only possible vaginal delivery is in this. So rest both of them I will have to go again for LSCS only. Now written persistent brow, why I have written, just by the way, because brow is a transient position. Okay, my dear students, brow is a transient position. So brow in early labor I can wait and watch, just by the way, because brow is midway. So brow can become further flexed. If brow will further flex, it becomes vertex. And brow, if it further extends, it can become face. So depending on, but if it's a persistent brow, so brow is a brow can convert. Okay, in early labor if it is there, you can wait for brow, because brow can get changed to vertex, where then of course a vaginal delivery is possible. And face also, then depending on where it changes, if it becomes mento anterior, again vaginal delivery is possible. And if it becomes mento posterior, what will I do for mento posterior? Anybody, what will I do for mento posterior? Again LSCS. Okay, so please keep all these points in mind. Okay, yes, excellent, all of you, very good. Moving on to the next question, very important PPH topic. PPH associated with all of the following except. Okay, so in PPH we have got two types of PPH. What we need to keep in mind, PPH could be atonic PPH, which is the major cause, and also you have got a traumatic PPH. So atonic PPH, the uterus is not contracting. Traumatic, there is a trauma. So here you get all the cervical laceration, vaginal tears, okay, cervix, vagina, perineum में you have got trauma, and even rupture uterus. And atonic PPH is the most important cause. Okay, so here remember three things. Over distended uterus, if the uterus is over distended, twins, Polyhydro. Can anybody give me examples of over distended uterus? Twins, polyhydramnios, macrosomy, all that will cause PPH. So your multiple pregnancy, okay. And then remember students, so one I'm writing ODU. ODU, all of you know, over distended uterus. Second is your, remember, APH predisposes to PPH. And third, hypertensive disorders, preeclampsia, eclampsia. And even if you remember these students, it is absolutely very good. Okay, over distended uterus, all examples, APH, preeclampsia. So you know, sir, abruption is APH, and remember APH predisposes to PPH. That means whenever there is a abruption or placenta previa after delivery. Yes, very good. IUGR is the answer. Why? Because it is opposite of IUG. I told you, macrosomy, big baby. IUGR is a small baby, chintu baby. So IUGR, not much problem. Is it clear to all of you? So opposite of IUGR, macrosomy is going to cause PPH. Is this understood to all of you? And lastly, then why HELP syndrome? Why HELP syndrome should cause PPH? Very good. So HELP में होता है low platelets. Okay. So HELP is a complication of preeclampsia, and HELP is low platelets. So HELP may also, it is associated with preeclampsia. Okay, it's a complication of preeclampsia. So BP is high plus low platelets, very good, low platelets would lead to PPH. Okay, so IUGR is the answer to this. Yes, moving on. PPH treated with all of the following except, again very important. Yes, hemolysis, elevated liver enzymes, low platelets. Yes, very good. Anybody why? Yes. So sir, excellent, very simple MCQ for the upcoming FMGE. It's sir, PPH we can give prostaglandins. Anybody, which prostaglandins do we give? Sir, we can give PGE1, or just now I told you PGF2 alpha. We can give that. Packing can of course be done with your condom tamponade or pressure or packing. And B-Lynch sutures. What are B-Lynch sutures? So B-Lynch sutures are sutures which we place on the uterus. Okay, so how they are done, nobody is going to ask you, but like you can go from ahead anteriorly, okay, then come from behind, then again come from inside, come from behind, then come from ahead, and then tie both these knots together. So they are like suspenders. Okay, so they are B-Lynch sutures, are uterine compression. Uterine musculature. To compress the uterine musculature, that is the last resort before going for, if this also fails, in the only option left is hysterectomy to save the patient's life. Okay, last is hysterectomy. So, and before going with all this B-Lynch, we do stepwise devascularization. What is this stepwise devascularization? Means first I will ligate the uterine vessels or the uterine artery, and still if the bleeding is not getting under control, then I ligate the internal iliac. But in internal iliac, what will I ligate? In internal iliac, I will ligate the anterior division. Very good. Because sir, uterine artery is a branch of anterior division. Is this understood to all of you? Okay, because uterine anterior division gives rise to uterine artery. Okay, so this is the answer, very simple anatomy. Because posterior, what are the branches of posterior division? SIL, just by the way. Okay, superior lumbar, iliosacral, lateral sacral. Okay, SIL. So this is the answer. Because posterior hai, you are supposed to ligate the anterior division. Yes, moving on to again a very important methergin. We just now told you methergin is absolutely contraindicated in managing PPH in which of the following conditions, and why? वेरी गुड. सी और डी वही चूज करना है. गंगो 5, हाँ ओके 4. यस okay, so please pay attention that methergin we will avoid in two main conditions. Methergin we will avoid in two main conditions. Just 1 second, all of you, just a second. हेलो, हाँ बोलो, क्या हो गया? यस, हेलो हेलो. Yes, very good. So, very good. Dr. Rajani Ramchandran, perfectly correct. And sir, methyl ergometrin we will avoid in heart disease patient, because in heart disease as well as in hypertensive disorders, because it will increase the preload, it will increase the afterload. Okay. Okay, so eclampsia is the answer. Eclampsia or preeclampsia or hypertension, because it is going to cause increase in blood pressure. And heart disease patients also. Yes beta, induction of labor तो you avoid only, that is understood. Parth Acharya, induction में तो anyway नहीं कर सकते हैं. That's why the question is methergin is contraindicated in the management of PPH. You can't say will not, anyway you can't induce labor. Okay, induction of labor, so anyway we don't do. Main is your heart disease and hypertensive disorders. So here, can I use it in a multiparas patient? Yes sir. Multiparas is a patient who has had 2, 3, 4, has got 3, 4, 5 deliveries. She is at a high risk of PPH. You can give her even previous LACS after delivery in the management of PPH. This also I can give. Is this understood to all of you? So why 4th is not the answer? Yes, can I get thumbs up? Because sir, in your multiparas patient and in your previous LACS there is no problem. We can definitely give methergin, can be used. There is no reason to avoid it. Heart disease and hypertensive disorders, which is your preeclampsia, eclampsia, we will avoid using methergin or methyl ergometrin. Is this understood to all of you? Yes, it's a very nice question. And just for the concept clearance, it will come in the NEET PG, likely to be coming in FMGE also. Twins. Yes, Rafik, increased blood pressure, increased preload, afterload, everything. So heart disease patients can also die. So if you have previous twins, okay, yes, very good. The history of twins. So now she is pregnant again. So please understand this, why this MCQ you should know. Okay, sir, suppose one time, the first time the lady has delivered a twins, there are two babies, twins, this will not change the parity and gravity of the situation. Okay, gravida and the parity. Okay, so if this is considered as, but after the delivery, like suppose she was primary, we call it P1L2. Okay, P1L2 का मतलब है कि sir she has, this tells you it was a twin delivery. P1L2, that L stands for living babies. If both the babies are alive, okay, after the delivery, if both these twins are healthy and alive, we will call it as P1L2. Suppose it's a triplets and all the three babies survive, we call it as P1L3. L stands for number of living babies. Okay, so and the same patient, so she was P1L2 and now the same patient becomes pregnant again, so you call it as G2P1L2. Okay, the parity only changes once the patient crosses 20 days, but you change the number after delivery. Okay, so the answer is G2P1L2. Okay, L2 because assuming. Okay, so beta our time here you can give oxytocin. Okay, in heart disease, hypertension, of course oxytocin is given. Okay, so G2P2 नहीं बोल सकते, G3 नहीं बोल सकते. It's not that she's already is already 2 and then you add one more 3. Okay, so it's not that for twins, because there are two babies, you don't call this as G2. This is G1 only, first time pregnant. Okay, similarly also. Is it clear to all of you? So G2P1 is the answer now. Now she is G2P1. Okay, she is not G2, she is not G3. Okay, this is very important for the basic. Okay, so just keep in mind all of you, GPLA. Okay, gravida, parity. Okay, G stands for number of times she is pregnant, P is parity, L is living, and A is if there's any abortion. Okay, or she has undergone any miscarriage. Okay, so suppose there's a patient who had first time a miscarriage or an abortion and now she is pregnant again, and you call it as G2A1. Okay, this abortion, suppose a patient has an abortion, I have a patient who aborts at say around 8-10 weeks, then it is not considered, L will be 0, P will also be considered 0 only, because P only happens after 28 weeks. Okay, so G2A1. Okay, G2A1. Okay, and after the delivery, if there is a pregnant life, then she is called as para1 living 1. Okay, if this next time this baby, the second time pregnant, if this lands up in a live birth, you call it as P1L1 A1. You can add this lady becoming pregnant again, then you call it third time, G3. G3 P1L1 means what? So this is a third time pregnant, one baby alive, one baby was a miscarriage. Okay, yes, so keep this in mind. Okay, moving on. Yes, again a very hot topic, trisomy 21 detection. Lots of questions coming on this topic now. Yeah, very good. So which of the following is not true? When you look at the babies of trisomy 21, we'll discuss NT scan. Of course sir, NT is going to be more. Okay, similarly PAP A we will discuss in some time, is a part of which test again is going to decrease. So this is correct, this is correct, and yes, alpha fetoprotein. Very good, Ankit, Pindaria, and all of you, Dr. Upadhyay. HCG is going to increase. That is the answer. Okay, HCG is a part of all the tests. HCG, whether you do a double marker test, I'm writing DMT, you write a triple marker test or quadruple marker test, in all of them HCG is a part, and HCG is always higher than normal. So in babies of trisomy 21, HCG is higher than normal. Alpha fetoprotein is going to decrease in trisomies. We'll discuss the interpretation and also the triple marker test in some time. It's a very hot topic. So HCG cannot decrease. Okay, yes, again a similar, very important. Yeah, we are going to discuss that Pranav. We are going to discuss the timing also in some time. Maternal serum alpha fetoprotein elevated in all except. So suppose isolated, you do MSAFP. Yes, same logic. Just look at the previous question, sir. Maternal serum alpha fetoprotein was decreased in trisomy 21. So please, when we ask the students ulta this question, they get confused. Alpha fetoprotein is of course increased in neural tube defects. It can increase in any condition where the baby has a problem from year to year. That means esophagus, liver, kidney, intestine, omphalocele problem, kidney, if the baby has any renal problem, liver problem, intestine problem, all these cases also, and IUFD also initially it is high. Okay, Down syndrome में alpha fetoprotein is going to go down. Okay, yes. Okay, so now I have got a 18-year-old girl comes to us with menorrhagia, heavy bleeding, heavy menstrual bleeding, heavy menstrual bleeding, which is the meaning is menorrhagia. Why? Which test is generally not advised? Anybody? Yes, a very simple question, very logical question. That point number 1, of course we would want to do her CBC, and when young girls, this is basically an example of a puberty menorrhagia. So when I have a patient of puberty menorrhagia, we need to rule out any clotting disorders. Okay, whether the blood, so you need to rule out ITP and even von Willebrand and all that. So complete platelet count, not only I do platelet count, we do even BTCT, which is bleeding time, clotting time, and prothrombin time, activated partial thromboplastin time. All these tests are specifically done for patients of puberty menorrhagia, because the young patients, and they could have this bleeding disorder. Till the time you check this, rule out this and give treatment for this, the menorrhagia will not come under control. So coagulation profile, very important we do. And yes, even though it's unmarried, does not matter. Today many girls are sexually active, majority before even marriage. We get lots of even Hello. Was the audio clear in the fast? Okay, just a second, all of you. Just 1 second. It was thought to be done in dead babies. Okay, gravida, parity, omphalocele problem, kidney, the baby has any, does not matter today, many girls are. Yes, all okay, yes. Okay, I thought yes. Yeah, no, I thought this was on. Yes, so pregnancy test should be ruled out. Now why pregnancy? Why pregnancy test to rule out? Why rule out pregnancy? Because please understand, प्रेगनेंसी में मेनोरेजिया नहीं होता है सर, प्रेगनेंसी कॉम्प्लिकेशंस. Is it clear? Why is it important to rule out pregnancy? Because sir, pregnancy complications means what? Sir, like a miscarriage, like a abortion. Here also patient comes with history of passage of clots. Similarly, even ectopic pregnancy, she can come with heavy bleeding sometimes. So sir, pregnancy complications like a miscarriage, there is a risk of, yes, you need to rule out abortion and ectopic pregnancy. Very good, because you will feel that he is having menorrhagia, but the management completely changes if there is a pregnancy, then the treatment is different. Okay, so pregnancy complications need to be ruled out, and therefore similarly even ultrasonography you should do. So I will do A also, B also. Dilatation curettage, isn't it? DNC, no. DNC is never to be done in young girls because not required. Okay, unless it's like a pregnancy thing and all that. So these are all young girls. There's no need to do a DNC. Which age group? Because the DNC is mainly for histopathology. Anybody can you tell me which age group I will surely do a DNC? Which age group if I tell you? And why? Which age group? If I tell you we have a patient of menorrhagia and I have a girl who is say 15 to 18 years. I have a girl who is say 20 to 25 years old. I have got a patient who is say 30 to 35-year-old, and I have got a patient who is 45 to 40. Which of the following? Yes, very good. Why Pranav and Dr. Humble? Why in this lady or even 40 plus? Yes, not 35 but after 40. Yes, so after 40 basically we should always do a DNC first. Why? DNC or histopathological examination. Why? HPE. Yes, you need to not Asherman beta, Asherman nahi. Adenomyosis cannot be ruled out beta. Yes, we need to rule out, because in 45 plus or 40 plus the cause heavy menstrual bleeding menorrhagia, we need to rule out endometrial hyperplasia, endometrial cancer. Very good. Okay, so endometrial hyperplasia, endometrial cancer needs to be ruled out. You need to rule out, and that can only be ruled out by doing a histopathology. Is this clear? So because ek tukda lining ka, yes, so 40, because hyperplasia cancer is only the diagnosis under the microscope. So in a young girl with menorrhagia we need not do a DNC. That is the answer over here. The same patient was say 45 plus, definitely I will first do DNC, मतलब hyperplasia cancer rule out करने के लिए a DNC would be done. Is this understood to all of you? Yes. Again a very important MCQ. Missed abortion. What is the meaning of missed abortion? Yes, anybody? Missed abortion is not diagnosed if yes, very if you read at the option, yes. What is the meaning of the word missed abortion? Sir, missed abortion is a condition in the first trimester. We are in the first trimester, please remember. So you don't call it IUFD. You don't call it IUFD because IUFD is used in the third trimester where the baby is there 28, 30, 32 weeks. So it's called as the early fetal demise. Basically missed abortion is that sir, it is say whatever 6 weeks, 8 weeks, 10 weeks pregnancy. Sir, either the heartbeat does not start only, baby heartbeat, or when I say that gestational sac tha, yolk sac tha, fetal pole tha, okay, in early pregnancy. So inside this fetal pole, there is fetal cardiac activity absent. When the fetal cardiac activity is absent, that is the time when we call it as, but the dead baby is still retained inside. That baby has not yet expelled out by the nature, okay, by the body. So fetal cardiac activity is absent, so they can have a bleeding brownish in color. Uterus stops growing because pregnancy stops, so uterus will be smaller. Os could be closed, that's okay. But if the USG is showing cardiac activity, that is a normal pregnancy, that's a normal healthy pregnancy, isn't it? If the heartbeat is still present, you can't call it missed abortion. And anybody, what is the treatment of missed abortion? What do you do? Okay, so heartbeat, if it is present, it's normal, it's a good sign. Fetal cardiac activity here is present. Okay, I told you fetal cardiac activity should be absent. So fetal pole, so either sometimes the heartbeat starts, fetal heart sound starts and then stops, or does not start only. And what is the treatment of missed abortion? Anybody? Chalo, what do you do for missed abortion? Basically it is of course the baby is dead. So what are we going to do for missed abortion? You need to evacuate the uterus. Basically you need to clear the pregnancy. So how do we treat it, sir? Either by doing a surgical suction evacuation or a dilatation evacuation, or yes, you don't call induction, yes, termination, but don't use the word MTP, or we can give misoprostol also. Okay, misoprostol can be given. Okay, misoprostol tablets can be given. Basically you need to evacuate. Yes, don't use the word DNC. DNC is used for basically gynec patients, menorrhagia. Yes, but we are going to discuss Aisha, we are going to discuss the misoprostol dose in some time. Okay, so either tablets can be given or suction evacuation or dilatation can be done. Okay, now threatened abortion. What is the meaning of threatened abortion? Threatened abortion is what? So there is a difference between threatened abortion and missed abortion. Very good. In threatened abortion, students, no. Beta D nahi ऊपर है. The question is, it is not diagnosed if. Okay. Yes. So threatened abortion is a condition where there is a threat. Yes, there is a threat. So there could be vaginal bleeding or spotting. There could be a little bit pain also. Okay, but the uterus, the baby is normal. The baby is normal. The heartbeat is, fetal cardiac is of course present. Uterus keeps on growing as per the weeks because the os is closed. If the os is open, then it is called as open os. Is seen in which condition? Open os is seen in your inevitable abortion, or also in incomplete abortion. Okay, in inevitable abortion or incomplete abortion is when we see os is open. Okay, so inevitable abortion or incomplete abortion, the os is open. There you cannot continue the pregnancy, you need to then complete the abortion, make the process complete. Okay, so os is closed. So here this is the answer. Internal os is not open, os has to be closed. Which beta, how to differentiate? Yeah, so what is inevitable and incomplete? Again on ultrasonography. Okay, inevitable means the pregnancy is still inside. Okay, os is open, and incomplete matlab there is again going, incomplete means what? She has already started passing some blood clots. She has already, half the products are complete. Okay, incomplete abortion there can be a lot of bleeding. Incomplete abortion they come to us with heavy bleeding. Okay, generally heavy bleeding, clots. Okay, because she has passed some products and some products are still inside. So on ultrasonography you will see retained products. Ultrasonography you see retained products of conception. Okay, yes. Okay, so that is what happens in threatened abortion. The os is closed, os cannot be open. And of course period of gestation will not match na, because here incomplete abortion she has already passed, so uterus will again be slightly smaller than weeks of gestation. Okay, is it clear to all of you? Yes. Yes, twin peak sign is seen in which of the following? A, B, C, D. C, A, B, A, B, C. Yes. Okay, C ka, yes. Okay. No, but Ankit also, yes, you can just doing a hysterectomy for a V mole is like too much. Suction is always better. Yes. So now here, why the answer is not B? B to clear hai. Monochorionic twins, what you see, I will tell you. Here you see a T sign or a inverted T sign. Okay, T sign or a inverted T sign is what you see. T sign or a inverted T sign you see. Yes, but dichorionic twin is the answer. Dichorionic twin is the answer. Dichorionic twin is the answer. In dichorionic twin, we will see the twin peaks and the lambda sign. That also I will tell you. Why is the answer not all monozygotic twins? Why this is not the answer? Because remember students, that's a monozygotic. Okay, twin peak sign or lambda sign. Why is it not all monozygotic twin? Because monozygotic twin is of 4 types. Sir, monozygotic twins could be dichorionic diamniotic. Yes, but it could also be monochorionic monoamniotic, and it could also be monochorionic diamniotic, MCDA. Okay, and it could also be lastly the conjoined twins. So your monozygotic twins are of all these following types, and therefore only in this DCDA, MCDA, MCMA you don't get this, and therefore that is the answer. That why not all monozygotic twins? Because our monozygotic twins could be both. It could be dichorionic as well as monochorionic. Okay, is it clear to all of you? Okay. Okay, so please pay attention. Yes, so now what is this twin peak sign or lambda sign? That's in monochorionicity. There is this vertical line, this is the placenta. So this is a right angle relationship between the this vertical line is the membrane, this is the placenta. Okay, so this is the monochorionicity. Okay, and in dichorionicity, this placenta runs for some distance in between the fetal membranes. Okay, placenta runs for some distance in between the fetal membrane. Suppose this is the placenta. All of you can see the black color placenta. Okay, so this is basically telling you two fused placenta. Is this understood to all of you? It is telling you two fused placenta, and that is the thing of dichorionicity, the lambda sign or the twin peak sign. Okay, is this understood to all of you? Okay, yes. So now please pay attention. Very, very important. After this obstetrics, lots of gynec MCQs now coming up. Best investigation for tubal patency is which one? Yes, so please pay attention. Yes, so HSG is a X-ray. We'll show you many HSGs today. It's a shadow. It is not confirmatory because the tube can undergo spasm. We may get false positive, false negative. Please understand this. Similarly, this is a ultrasonography, saline infusion sonography. So HSG, Dr. Upadhyay, is not the best. Okay, HSG is the initial investigation. It's the initial investigation because it's a X-ray, it's a OPD procedure. There is no cut or stitches required. There is no surgery. Okay, hysteroscopy we will discuss in some time, is to see the cavity of the uterus. Okay, it is to see the cavity of the uterus. And laparoscopy. Okay, laparoscopy is the best investigation. I will show you the picture in some time. In laparoscopy, what we do, we can put a methylene blue dye. We put a methylene blue dye, which is the laparoscopy के साथ we do laparoscopy के साथ we do this methylene blue dye is called as chromopertubation. Okay, this laparoscopy chromoperturbation picture I'm going to show you in time. Yes, no, but it's not investigation of choice for infertility. It depends, na? Investigation choice for what? Infertility matlab how? Whether if it's a male partner, you do semen analysis. For female partner, if it's PCOS, you do ultrasonography. AMH for ovarian reserve. It's not like investigation for infertility. If you want to completely evaluate the female, then you can do combined hysterolaparoscopy. Okay, I understand. Okay, so laparoscopy chromoperturbation or laparoscopy methylene blue dye test is the answer, because it is the best investigation confirmatory. What is done is, quickly I'll show you the picture also. What is done is, let's say this is the uterus. Okay, we put a telescope from above and we see the fallopian tubes with our own eyes, and we also see the uterus, and we put a blue color dye. Methylene blue dye is taken. And the assistant puts the dye into the cervix. Okay, through the cervix the dye is pushed away, so dye will enter the tube and then the dye will come out, and the dye will come out from here. We'll show you the picture. So the tube is patent. Okay, so it is the best investigation for tubal patency. Yes, now hysteroscopy is for all except. Can anybody tell me why? Again, a very, very important MCQ. Very good, very good. So sir, hysteroscopy tells us lot of information. Hysteroscopy is what basically, students, I am putting in a telescope through the cervix to see the cavity of the uterus. So where all it can help me? Sir, suppose inside the cavity there is a polyp, there is a fibroid, okay, or there is a septum, then all, or there are any intrauterine adhesions. So if I have a patient who is, suppose say, having menorrhagia or a fibroid or infertility, all that cases, this what I told you, anybody, this intrauterine adhesions is called as Asherman syndrome. Again, a very popular MCQ, intrauterine adhesions. Okay, so if inside the uterus there are intrauterine synechae, that is called as Asherman. Okay, but in TB actually HSG is not done. Okay, in TB, if you know it is confirmed tuberculosis, Dr. Convo, then you don't do HSG because infection can spread. It's a by the way, it's a silent infection. So you do the HSG, then you come to know. Confirm again always any abnormality on HSG, confirm by laparoscopy. Okay, by the way, if you see any abnormality on HSG, you need to confirm by doing a hysteroscopy or a laparoscopy as a confirmation. Okay, so Asherman syndrome, of course, hysteroscopy will help. Polyp also it will help. Septate uterus also, all three I have shown to you. This is what it is. Okay, any cavity problem, septum, polyp, fibroid, Asherman, all that it will help. The answer is of course very good, endometriosis, because in endometriosis everything is outside, isn't it? Sir, endometriosis is the answer. In endometriosis I do a laparoscopy. Endometriosis we do laparoscopy. Laparoscopy is the investigation of choice because in endometriosis things are outside. You see a chocolate cyst, blue, brown, black color lesions, all that. So endometriosis requires laparoscopy to be done. Okay, yes, very, very important. When I want to check anybody's FSH and LH level, then when do we do it? Which day of the cycle? Okay, so please remember, students, whether PCOS or not, whether it is PCOS or not, any patient, when I want to do LH and FSH levels, it is always to be done on day 2 or day 3 of the cycle. Reason, nobody is going to ask you, but I want to know the baseline level, because as the cycle will progress, day 2, day 6, day 8, day 10, day 12, all of you know we are going to get a falsely elevated reading. So if you do it later in the cycle, we'll get higher readings, and therefore FSH LH should always be done on day 2, day 3. More important, we should know what is the normal ratio of FSH to LH. The normal ratio is how much? So normally it is 2 is to 1. This is normal. And what happens to PCOS? It is 1 is to 2 or 1 is to 3. Okay, this 1 is to 2 or 1 is to 3. Okay, in PCOS the ratio becomes inverted or alter. Okay. Fothergill's repair. Anybody? Fothergill repair is now almost a outdated surgery. Which condition we used to do it and why? It was done as a surgery for prolapse uterus, but in a young patient of prolapse. In a young patient of prolapse, we do Yes, very good. So what happens is that in Fothergill surgery, what was the main step? So in Fothergill surgery, one of the main step was cervical amputation. Okay, cervical amputation was being done. So when there is cervical amputation, no, cercalage we don't do in the first trimester. Okay, Abhishek, cervical and cercalage always done after 14-16 weeks. That is if required. Okay, Abhishek Mishra, encercalage is a treatment done. Encercalage is a treatment done for os incompetence. Yes. So cervical amputation can lead to, what happens is that, sir, it can lead to cervical incompetence, or cervix can become too tight and stenosis. So what all can happen is there is a risk of preterm labor, there is a risk of infertility, there is a risk of cervical dystocia. Dystocia matlab during delivery the uterus contract but the cervix does not dilate, but it will lead to anybody. Cervical incompetence will lead to always abortion. When? Always in the second trimester and never in the first trimester. Is this understood to all of you? Yes. And that is the reason why first trimester abortion is the answer. It should have been second trimester. Okay, second trimester. Okay, is the answer. Yes. Moving on, what is this device, anybody, and how much hormone does it release per day is the question. Yes, so the hormone released per day from this device is basically, this is a LNG intrauterine device, also called as LNG 20, also called as LNG intrauterine system, and of course Mirena is the brand name. Mirena is the brand name. Now lots of brands are available. When it had come, it had only one brand, Mirena. So here, yes, the question is now released per day. Per day, what is the answer? Okay, so please don't get confused. Totally it contains 52 milligram. And why do I call it LNG 20? Because sir, 20 microgram is released per day. Is this understood to all of you? So please don't get confused. Both questions have asked in the exam. Please read the question correctly before answering, because total, if the question was total, then total is 52 milligrams. But the question asks per day, not 20 milligram, 20 microgram. Okay, 20 microgram is the answer. Okay, that's the answer. It has got lots of benefits. Basically, what happens to the menses? Can anybody tell me? Once I insert Mirena in the patient, what happens to the menses? Once I put it inside the uterus, what happens to the patient's period? Bleeding will keep on decreasing. Periods become scanty, and periods can also stop because of continuous progesterone, and therefore that is why it has been used in treatment of heavy menstrual bleeding and endometriosis and all that. Okay, so I can use it in treatment of heavy menstrual bleeding, menorrhagia, endometriosis, and it can also prevent endometrial hyperplasia. Okay, yes, endometrial hyperplasia, yes, basically doctor, I corrected, it causes amenorrhea. Over a long term, if action is very good, menses become less, and menses can also stop temporary. So it induces amenorrhea in the patient. Okay, yes. Absolute contraindication for IUCD is which one? Again, a very popular for FMG. Is the absolute contraindication. Nirmala, I didn't get your MC change ectopic. I don't understand. Most common change ectopic. I don't get the top. I didn't get the thing. Yes, correct. So please understand this, that out of all these, please understand, nulliparous patients, we generally avoid a copper T or IUCD, but can be inserted. It's not that in nulliparous you cannot. Absolutely, yes, you can. And please understand, ectopic IUCD is wrongly blamed for ectopic. IUCD does not increase the risk of ectopic pregnancy at all. Okay, so past history of ectopic, there is no connection. Even if the patient has got past history of ectopic, if she wants birth control, IUCD can be inserted. Yes, acute PID is the answer, not all of the above. So very quickly, acute PID, basically any active infection, acute PID, puerperal sepsis. Okay, acute PID, puerperal sepsis. Okay, then okay, acute PID, puerperal sepsis. What else? Undiagnosed vaginal bleeding. Yes, and your cervical cancer, endometrial cancer, and very importantly, there's uterine anomalies. There are two horns, bicornuate uterus. How will I put the copper T? Copper T will not fit. Similarly, the cavity is distorted. There's a fibroid here, there's a fibroid here, there's a fibroid here. So multiple cavity distortion, and even remember students, following vesicular mole. This was asked in last year. There's a V mole. Then after V mole or gestational trophoblastic neoplasia, the uterus is very soft. It can lead to perforation. Okay, so acute PID, puerperal sepsis, any active infection, undiagnosed bleeding, pregnancy. We are going to come better. We are going to come in that. Next question is coming. Okay, gun ho. Okay, yes. So all these cavity distorted. Now, absolute contraindication for OC pills is which one out of the following? Which mothers, which patients I cannot give OC pills? Combine oral. Combine matlab it is estrogen plus progesterone, both. Yes. So if smoking patients who smoke, we definitely avoid OC pills. But few cigarettes in a day, you tell the patient to stop smoking, but OC pills can be given. If it's like very much like age more than 35 and more than 30 cigarettes per day, then you absolutely. Uterine anomalies तो कोई problem ही नहीं है. Uterine anomalies, of course, uterine anomalies is a contraindication for IUCD. Okay, for IUCD. And breastfeeding, so remember two with the breast. Okay, OC pills, when you now look at it, is liver disease. OC pills का absolute contraindication क्या क्या है? Acute liver. What else? Can you tell me three four contraindications for OC pills? Absolute contraindication for OC pills. Anybody? Yes. One is active liver disease. What else? Both breastfeeding. Why breastfeeding? Lactating mothers, breast cancer, even past history. Okay, yes, because estrogen decreases quality and quantity of milk. Therefore, breastfeeding is the answer. Okay, lactating mothers, you can give POP. Progesterone only pills can be given. DMPA injection can be given. IUCD can be given. Okay, all of the following can be used by lactating mother except. So POP, DMPA, progesterone, IUCD, all that is okay in lactating mother, but not your this. Okay, yes, thromboembolism, DVT, heart disease, okay, stroke, all these patients, and complicated migraine. कॉम्प्लिकेटेड माइग्रेन का मतलब है, कॉम्प्लिकेटेड माइग्रेन का मतलब है कि migraine with aura. Okay, there's any migraine with aura. Yes, DVT comes. Okay, DVT, thrombosis, heart disease, plus syndrome, breastfeeding, breast cancer, severe, very good, severe diabetes, uncontrolled diabetes, hypertension, all that. Okay, yes, again a very important simple MCQ. LH peak, all of us know LH will lead to ovulation. So how and when? LH peak, yes. So remember students, in this picture, very simple. Let's say from the LH hormone onset to ovulation, it takes 36 hours. Onset to reach the peak matlab the maximum levels, it takes 24 hours. But after the peak is reached, 12 hours the ovulation will take place. Okay, so your LH peak पूछा है, and therefore 12 hours is the answer. If the question was LH surge onset, precedes ovulation by, then you can mark 36 hours. Okay, then you can mark 36 hours. Yes. Okay, so please keep this in mind. Yes, which of the following again is a definition of primary amenorrhea? Nihar, I have not seen what is the technicality issue. Nobody has complained ever. I'll just pass on the message to them. Okay, I'll try to help you. I'll just tell you. Okay, yeah. But what exact problem you are facing? Yes. So now please pay attention. This is very important, that when there is 13, 14, 15, 16, all these are the confusion. So remember students that the old definition was 14 years and 16 years. This is old definition which has been revised in the last few years. It's very very important because age of menarche. So olden days, few years back, just 2-3 years back, we were telling that sir, if the girl is 14 years and there is no menses and there is no secondary sexual characters, SSC. SSC is secondary sexual characters, because all of you know thelarche, pubarche, menarche. So there's breast development, axillary pubic hair development, then this is, you can wait for some time. And this, if the breast and axillary pubic hair are present, then you can wait even till 16. This now has changed by one year. This 14 has become 13 years and 16 has now become 15 years. Very good, all of you. So this question surely will come. And therefore 14-year-old girl, no menses but with breast development. So since the breast development is there in this girl, I would like to wait for 1 more year, isn't it? Because breast development is there. So this is not the answer. Similarly, 13-year-old, no menses but again with breast development has started. There is thelarche. So pubarche, menarche, we can wait. We can wait till 15 years. So that is again not the answer. Very good. Option number C is the answer. 13-year-old, no menses and still there is no breast development. Okay, so this you do not wait further, and this is the definition. This was old. 14-year-old, no menses without breast. This is the old definition. So if the MCQ was asked 7 years back, 10 years, 5 years back, 7 years back, then this D would have been the answer. Now you call it as 13. Okay, is it clear? So C is the, is this understood to all of you? So now you cannot wait. So 14 is wrong because 14 was the old bracket. So 13-year-old, no menses without breast development is your answer. Okay. Yes. Which of the following is not indicated or not a method for doing a MTP in the first trimester? So in the first trimester, of course, we can give misoprostol, mifepristone. We'll actually, it's order mifi is given first. We'll discuss this, and then you give meso. Okay, we use this medical method. We use manual vacuum aspiration also, and dilatation evacuation, also called as suction evacuation, also is used. Okay, the answer is this. Ethacridine lactate, first of all, is a old technique, and we do not, this is for second trimester, but also not into the amniotic fluid. Okay, there is a substance called as ethacridine. Ethacridine is a yellow color liquid. Okay, ethacridine is a yellow color liquid. This is the uterus. This is the pregnancy growing 16-18 weeks. So we used to install extra amniotically. Okay, yellow color. Okay, we put a catheter and extra amniotically ethacridine lactate used to be put inside the uterus. It's a yellow color, and then that will cause the membranes to separate, and that will cause contraction. So that is extra amniotic ethacridine. Okay, but that is for second trimester. Now hardly it's not even available. Okay, so that's for second trimester MTP. We don't use it. So this is the answer. Installation of ethacridine lactate into the amniotic chamber galat hai, and question is about first trimester. Okay, the question is about first trimester. Ethacridine, if at all, was used for second trimester MTP. Rest all. Okay, meso, mifi, dose, all that we are coming to in some time. Yes, now very very important. CA cervix stage 3B. Treatment is what? Based on the following options. Yes. So very good. Please pay attention. That stage 3B is inoperable. No, Dr. N. Kumar, no. Okay, you can't do a Wertheim hysterectomy. Wertheim hysterectomy is only for 1A to 1B and up to 2A only. Only these three stages. Simple hysterectomy is for your, not for cancer. Simple hysterectomy is what I do for a fibroid or a prolapse or a menorrhagia. And when the answer only CT is wrong, radiotherapy is the answer. But now see this. This one more question came. Now tell me the answer. CA cervix stage 3 treatment. Now tell me the answer. So this question I purposefully selected back to back to clear the confusion of the student. Again, all of you should know Wertheim hysterectomy is out. Is it clear? Wertheim hysterectomy is for which stage? Sir, only up to 2A. Very good. Simple hysterectomy is out. Chemotherapy is out. So very good, students. In the previous question, see, only chemotherapy is out. Radiotherapy is the answer when only these are the options. But before radiotherapy, so radiotherapy is teletherapy, brachytherapy. We also give cisplatin. Cisplatin is given to the patient as a radio sensitizer. And therefore, when RT and CT-RT both are in the option, very good, somebody told me chemoradiation. So concurrent chemoradiation or CT-RT is the word to be used, and therefore CT-RT is the answer. CT-RT is the answer. Okay. So when both are in the option, I repeat, students, that when RT and CT-RT both are in the option, then CT-RT is better. Is it clear? It is better than only RT. Both actually technically mean the same thing only. Cisplatin is given, but you call it concurrent chemoradiation or chemoradiation. So CT-RT is better option than RT to mark in the exam. So when CT and RT separately, mark RT. But when CT-RT and CT-RT separately, then mark CT-RT. Okay? Yes. This is what we were discussing. Dual marker test. Somebody said when to do it. Dual marker test is done between 11 to 13 weeks of gestation. Okay, keep in mind 13 से थोड़ा ज़्यादा तक कर सकते 13.5 weeks, 13.6, but 11 weeks के बाद in the first trimester. We are doing it in the first trimester. Okay, some even say 11 to 14, but 11 to 13 weeks. Yes, and inhibin A is not a part. Okay, inhibin A is not a part, and you don't do this. It is HCG and PAP-A, pregnancy associated plasma protein A. HCG and pregnancy associated plasma protein A. All of us know HCG will be higher than normal, PAP-A will be lower than normal. Yeah, Yashwant will discuss that one. Okay, amnios, and when we do again, this question is coming. Okay, never. Okay, so is this clear to all of you? Now, suppose if I ask you quadruple marker test. So quadruple marker test is done in the second trimester. So 11 to 13 is out because that is the time to do a dual marker test. Remember, students, triple marker test and quadruple marker test both are done at the same time, 16 to 18 weeks. Okay, 20 to 24 is 2 days. Okay, 16 to 18 weeks is when you do it. Okay, yes. And what are the four things in quadruple marker? HCG, alpha fetoprotein, unconjugated estriol. Don't make a mistake when you students say estradiol. Estriol is E3. This is a part of your triple marker test. And to that, if I add inhibin A, and all of us know this goes up, this goes up, this is low, this is decreased. Okay, yes, it is estriol and not estradiol, not E2. Please keep in mind. Okay. So all these are very, very hot MCQ. Yes, now comes your question. Can you see the picture being done? Can you see an image over here? I should just shift it. Okay. Yes. So what is this picture? Okay. Okay. So in this picture, we have a USG probe given to you. We have the baby. Yeah. But can you see the needle over here? There is, and the fluid. Okay, basically we are poking in a needle. Okay, this is amniocentesis. Okay, I'm drawing the needle over here for better simplicity. So in this fluid, in this picture, the needle is in the amniotic pocket, and amniocentesis. Basically, amniotic fluid is taken around. Now, if I tell you what is the answer, it is amniocentesis. Okay. Now, all of you can see the needle clearly. The needle is in the amniotic fluid and amniotic section. So, amniocentesis I don't do at 10 to 13 weeks. Very good. Amniocentesis is done between 16 to 18 weeks for karyotyping. Okay, because for the purpose of trisomy 20. Later in the pregnancy also, if there's severe poly and mother cannot breathe, then I can think of doing amniocentesis at 30 to 34 weeks. But here they have said that for detecting trisomy 21. So you can't wait till 36 weeks to wait for trisomy 21. So that is out. Okay. So remember students that when I want to do karyotyping or confirmatory testing, we have got either a chorionic villus sampling, which is done in the first trimester. Okay. Who would ask me that out? Somebody had asked me. Okay. Yeah. Yashwant. Okay. And if I have to do amniocentesis, we do it in the second trimester. Okay. Second trimester. So chorionic villus sampling is best done in the first trimester, amniocentesis in the second trimester. Okay. Is this understood to all of you? Yes. Now, what is this image-based MCQ? Two pictures are shown to you. What is it telling you? Just a second. Yeah, just 1 second. Yes, so this is a picture of color Doppler, and color Doppler, remember, yes, this you please don't mark as confirm ectopic. That is just wanted the take home message. This is of course the ring of fire, and remember students, ring of fire, that's around this mass. You see a lot of vascularity, you are seeing a color Doppler and whatever. So this is suggestive of, I'm writing SO, suggestive of ectopic pregnancy. Is this understood to all of you? Snowstorm appearance is for VMOL. We'll discuss that also. So please don't make simple mistakes like this. All of you know that ring of fire is very highly likely or suggestive of ectopic pregnancy, but not confirmed. Moving on. Yes. Now can anybody tell me what is this picture? What we are seeing is the image of what? Image of what? Yes. So all of you, we can see the triangle uterus. We can see the triangle uterus. Yes, can all of you? Yes. But can you see normal HSG? What would have been? Sir, uterus. and then very nicely thin, bouncy, wavy tubes, and then spill, yes or no, that will depend. So fallopian tubes. So this is definitely not a normal HSG. We are not seeing two separate cavities. Bicornuate uterus, we would see one horn and then another horn, two horns wide apart. That would have been a bicornuate uterus. Okay, and this clearly, students, all of you can see that, sir, fallopian tubes are not seen only. Are you seeing this? Okay. Okay, clearly if you see, then this fallopian tube is missing, okay, and there is no spill. So clearly what is happening is only the outline of the uterus is seen, which is telling you that, sir, it is a bilateral cornual block. Of course I need to confirm it by doing a laparoscopy. It's a bilateral cornual block. It's a bilateral cornual block which is present. Okay, so bilateral cornual block is there. Because only the uterus outline is seen and the fallopian tube is absent. Fallopian tube is absent मतलब not seen. Fimbrial block में क्या होता है? Anybody? What would have been in fimbrial block? Say fimbrial block would have been something like this. Yes, sir, if there is a block in the fimbrial area, then the tube would get distended, hydrosalping, there will be a block and there will be no spill seen. So fimbrial block mein at least the tube is seen till the end, okay, and the tube is distended. So if you get this picture, then you call it as a fimbrial block. Okay, is it clear to all of you? Suppose you get this picture. Okay, so tube is seen, and then the tube is blocked, and generally because if it's blocked at the fimbria, it will get distended. Okay, so this picture is called as fimbrial because the dye is seen all the way till the fimbrial end. Here I am only seeing the uterus, so it is a cornual block. Okay, yes. Now what is this picture? Anywhere where you see laparoscopy, this is the uterus, this is the ovary, this is the fallopian tube, and if you see this blue, okay, yes. So please, and no beta, this is not hysteroscopy. This is okay. In hysteroscopy you are seeing inside of the uterus. Please see my lecture in detail to get an idea. Hysteroscopy mein we see the inside of the uterus. Hysteroscopy mein I never use methylene blue dye. Here I am seeing the uterus from outside, isn't it? I can see the actual uterus, actual ovary. Please don't get confused. Okay, the views are completely different. Hysteroscopy, I directly put a telescope inside the uterus and I only see the cavity of the uterus. Wherever when I see the uterus like exactly as it is, if I have to see the tube, it has to be a laparoscopy view. Is this understood to all of you? Moment you see the ovary and the whole tube, it has to be laparoscopy. And in this clearly we can see that, sir, we are seeing the blue color dye. The blue color dye is coming. Which is that blue color dye? The methylene blue is laparoscopy chromoperturbation, what we just now discussed for infertility, the best investigation for tubal factor. Okay, हिस्टेरोस्कोपी में ऐसा यूट्रस नहीं दिखता है, ऐसा ओवरी नहीं दिखता है, ट्यूब नहीं दिखता है. ओके, इज इट क्लियर टू ऑल ऑफ यू? यस. Similar, yes. NT scan, very popular. When do we do NT scan? What is the cutoff for NT scan? So NT scan is a nuchal translucency, nape of the neck. At the nape of the neck, the baby has some translucent space. All babies have a translucent. Okay, the eye. Okay, so all babies, you zoom that part, and at the nape of the neck there is this. Yes, so again done at 11 to 13 weeks of gestation, and up to 3 millimeter is considered normal. Some say 3, some say 3.5, but if the NT is more than 3 millimeter, that is some danger. Okay, so NT scan is done at what weeks of gestation? 11 to 13 weeks of gestation. Okay, very important. And increase NT is a marker for, okay, venous delivery. Venous is vacuum. Yes, very good. So we have got to know, okay, we need to know the indications for instrumental delivery, forceps or vacuum. When we first look at the indications, please keep in mind, either it is maternal exhaustion, mother is exhausted after pushing, that could be because of prolonged second stage, okay, or a prolonged second stage, or I need to cut short second stage. Which condition I cut short second stage? Anybody? Any idea? When do I cut short the second stage of labor? When do we cut short the second stage of labor? Cut short the second stage in conditions like heart disease. Very good, where I don't want the patient to bear down too much. And third, very important, if it is any fetal distress at full dilatation, because cervix should be fully dilated. No, shoulder dystocia, you never apply forceps or vacuum, okay beta? Never, wrong. Nirmala, wrong. Okay, so shoulder dystocia is totally separate. Okay, so maternal exhaustion, cut short second stage or fetal distress is when you apply a forceps or vacuum. But please keep in mind that when we are applying a forceps or the vacuum, what about the pelvis? If it's CPD, is it okay? If there is CPD, cephalopelvic disproportion, is it okay to apply the instrument? No, never. Because please understand, you are putting all these instruments inside the vagina and getting the baby out. So there should be, and you should be very sure that yes sir, there is adequate space for the baby to come out. So remember students, whenever you apply a forceps or vacuum, there should be no CPD. Keep that point in mind. Okay. Okay, so delay in the second stage of labor, of course I can apply vacuum. Non-reassuring fetal heart rate, fetal distress also apply. Please understand, this question is about indication as well as prerequisite combined together. And remember students, that when I talk about prerequisites for vacuum, it cannot be face, because if there's a face presentation and I apply vacuum, eyeballs will pop out. Similarly, if there's only baby's buttocks which I see, again I cannot put it on the breech. So V for vacuum, V for vertex. Is this understood? Sir, vacuum is only possible in a vertex presentation. So vertex also should be there. Answer is this: prematurity. Sir, prematurity is a absolute contraindication for vacuum. Prematurity, absolute contraindication. Please write down for vacuum. Why? Because sir, when I pull the baby, there is more risk of intraventricular hemorrhage in preterm babies when we use vacuum. Is this understood to all of you? So gestational age should never be less than 34 because it will lead to increased risk of intraventricular hemorrhage. So in case if it's a preterm baby slightly, you may go for forceps but never vacuum. Okay, vacuum is only when patient is 37 weeks. So 36, 30, 35, 36 weeks, avoid 34 weeks, definitely avoid a vacuum delivery. Okay, so vertex होना चाहिए, मतलब it cannot be face and breech. Again, vacuum not possible. Okay, face and breech, again vacuum not possible. So vertex is here. Yes. Pritchard regime, very popular. All of you should know when we give magnesium sulfate for eclampsia or severe impending eclampsia. What should be the therapeutic range of magnesium sulfate to be achieved? Yes, 4 to 7. Please by heart this number, there is no explanation. 4 to 7 milli equivalents per liter is the this, and 14 grams. Don't make a mistake, it's not milligram. 14 grams is the initial loading dose. 4 gram is given IV and 10 grams is given IM in each buttock, 5 and 5. Okay, it is grams. So this all we need to know. Yes, when you have labor, what is the sequence of events? Now anybody, what is the sequence of events in a normal delivery? This kind of question also could be asked to you. Yes, so first is, yeah, okay, so keep in mind that whenever we are discussing labor, we'll discuss very quickly. So descent is a continuous process. Descent will always keep on happening. Descent is a continuous process. Engagement, labor starts with the process of engagement. That means the baby head enters the pelvic brim or the pelvic inlet. Then the baby's head will touch the pelvic floor. So what is the most important movement? There is internal rotation. So actually after engagement should come internal rotation, but they have not mentioned that in this. That's okay. Then what happens? After internal rotation, the head will come down further. There is going to be crowning. Okay, so internal engagement 1 के बाद आ रहा है 4. Yes, all those. Okay, 1, 4. Then there is, after crowning, what happens? There is head delivery. Head is flexed. So head delivery takes place by extension. Now there is, what is the meaning of restitution? Can anybody tell me what is the meaning of restitution? What is the meaning of restitution? Restitution is untwisting of the baby's neck. Okay, because when there is an internal rotation through 90 degrees, there is a twist on the baby's neck. So untwisting of the neck is called as restitution, which happens outside the body of the mother. And then followed by, it is actual. Anybody, what is external rotation? Sir, external rotation is actually nothing but internal rotation of shoulders. Keep this in mind, students. So actually it is internal rotation of shoulders, which is looking like external rotation of the feetlet. And why do we call it external rotation? Because it is outside the mother's pelvis or the body. So that is the correct. 1 के बाद 2 नहीं होगा, so A is wrong. 4 cannot happen first, 2 cannot happen first. Okay, so rightly told by all of you. Engagement, internal rotation, crowning head delivery by extension, followed by untwisting of the neck, which is restitution, and then there is external rotation, which is actually, remember it, and then the rest, and then the delivery of the shoulder. After external rotation, then there is shoulder delivery, and then rest of the baby will deliver by lateral flexion. Okay, so it is external rotation of the head, which is basically, I told you, it is internal rotation of shoulder. Okay, moving on to the next very important MCQ. Definitely a patient comes to you. Okay, MCQ, primary amenorrhea, uterus not seen on USG. Yes beta, deal with your, okay, yes, yeah, restitution beta is a untwisting of the neck. No, I told you, untwisting of the baby's neck, untwisting of the neck is called as restitution. Okay, untwisting of the neck is called as restitution. Okay, what is this? All those who are saying absent uterus directly mark the MRKH, please look further. Breast development is present, axillary and pubic hair is absent, axillary and pubic hair is absent. So what it is? It is not MRKH. It is not this, it is not this. Why? Because point number 1, whenever we have, please keep in mind, whenever I have a combo package of primary amenorrhea, absent uterus, please dear student, this comes every year in the entrance exam. No, it's not Turner's. Okay, Turner's syndrome, uterus is not absent, and Turner's syndrome you don't get by. Turner's syndrome will discuss MCQ in some time. Turner's syndrome is going to be streak ovaries, shield shaped chest, short stature, high arch palate, all that. Okay, so primary amenorrhea, absent uterus, only 2 possibilities, RMKH and androgen insensitivity syndrome. And the difference here is that, sir, RMKH, it is uterus is absent but the ovary is normal and testosterone is functioning. So here when you look at the axillary and the pubic hair, here it is of course well developed, and here it is going to be absent. So since you have got in the question paper absence of axillary and pubic hair, we know testosterone is not able, testosterone cannot function, testosterone cannot function, and that is the reason androgen insensitivity syndrome, the third most common cause of primary amenorrhea, complete androgen insensitivity syndrome. Please keep in mind, here you will have, otherwise features are very similar. Both of them have primary amenorrhea, both of them have well developed breast, both of them have absent uterus. Okay, breast is not a difference, breast will be well developed in both of them. If you look at breast, here also tick tick tick, here also tick tick tick. So the difference is only by axillary and pubic hair, which is extremely important. Mullerian agenesis, there will be of course absent uterus but axillary pubic hair or are well developed. Okay, keep in mind. Yes, again, what is the diagnosis based on the question paper in the question? Okay, infertility, dyspareunia, dysmenorrhea. Yes, last 15 minutes we'll discuss many MCQs now. We already discussed so many. Let's try till 12:25. Okay, yes, very good students. This is infertility along with dyspareunia, dysmenorrhea, our famous mnemonic DID, Dance India Dance. Okay, DID, Dance India Dance. This is very classical symptoms, and along with it fixed fixed matlab restricted mobility, retroverted uterus along with nodularity felt in the pouch of Douglas. This is suggestive of endometriosis. Okay, endometriosis is very very important as an MCQ. Okay, is it clear to all of you? Endometriosis. And in endometriosis, we told you laparoscopy is the investigation of choice. Laparoscopy is the investigation of choice in endometriosis. Okay, endometriosis, laparoscopy is the investigation of choice. Okay, because you need to see, when we look at the endometriosis, you will see the chocolate cyst and you will see all the blue, red, purple color, all the lesions of endometriosis. Okay, sonography HSG is only for tubes. Hysteroscopy we discussed is for septum, fibroid, polyp, adhesions, Asherman. Transvaginal sonography will only see the chocolate cyst, but other things of endometriosis which are there, okay, which you see. Okay, what we see in endometriosis, everybody, you see red color, you see red nodules, you see blue color, red, they are called red raspberry, purple raspberry, okay, blue lesions, all this you have to red, blue, purple, all these are called as endometriotic implants. They are called as endometriotic implants, which you need to see, which you can see with this laparoscopy. Yes, this is just a new thing now, not very new, all of you know this. Okay, that now the new guidelines came. MTP was allowed till 20 weeks and now we have increased it to 24 weeks because certain anomalies can be detected later, or if she is a rape victim or sexual assault victim. So now for the purpose of any baby or mother, we can do it till 24 weeks of gestation. Okay, is it clear to all of you? Yes. Treatment of decubitus ulcer in a patient of prolapse. Anybody? Yes, this is 22 ways to signature of 2 doctors. Yes. Treatment of decubitus ulcer in a patient of prolapse. Yes. So please understand what is decubitus ulcer. So decubitus ulcer is an ulcer which I see on the prolapsed part of the cervix. Okay, if this is the uterus and when the cervix is constantly exposed, okay, when the prolapsed part of the cervix, you will see a circumferential ulcer. It's a circumferential ulcer. It is complete round and it's a circumferential ulcer. Okay, around the part of the cervix you see the circumferential ulcer on the prolapsed area, and what we do is you take a tampon. What is done is a tampon. So this is absolutely, they want to see where what a tampon is taken and it is soaked with glycerine and acryflavin. Okay, so you don't do laser, you don't pack it with H2O2 and acetic acid, you don't do cryo, you will pack with glycerine and acryflavin. Glycerine is a hygroscopic agent. It will decrease the edema and help in repositing the cervix back inside. And acryflavin is a dye which has got a antiseptic property. It's a yellow color dye. It's a yellow color dye, okay, which helps in rapid healing and re-epithelialization of the ulcer. So keep in mind, this is also the PYQ, it can come again in the exam. Now again, this is a virgin MCQ, never asked till now, will come in the future. This is what? So this is, we are seeing the cervix of the patient. We are seeing the cervix. This is the speculum. Speculum border जो है, this is the cervix का anterior lip. This is the cervical opening. This is the posterior lip. So what it is? Okay, cervix का anterior lip, posterior lip and cervical opening. Yes, the important point is, yes, the whole picture. Very good, all of you. Clearly you can see, I can also see it on my screen, that clearly the whole picture is, sir, green in color. Green color picture is there, just to show you that this is a green filter. Green filter MCQ has been asked in the past exam, that in colposcopy, when we do colposcopy, which filter is used? It's a green filter. That's why green filter is nothing but a green color light. It's a green color light which you see. Okay, it's a green color light which you see, and through that green light, basically we can see the blood vessels better. If there are any blood vessels, remember green filter is done to see blood vessels. Okay, if there are any blood vessels on the cervix, then they are seen better with green color. Okay, so neovascularization. Okay, yes, ideal time to test a patient for gestational diabetes is what? When do you screen the patient? Screening for gestational diabetes, because sir, insulin resistance will develop during pregnancy, and insulin resistance is maximum when? Very good, 24 to 28 weeks, and that is the answer, not this. Okay, so any trimester but 24 to 28 weeks the insulin resistance maximum, and therefore we need to screen the patient at that time. Okay, now again a simple MCQ, long question, but first tell me the diagnosis. Patient has come to us for the treatment of acne and hirsutism. What is your diagnosis? She is having acne, also she is having irregular periods, LH 15, FSH 5. So sir, she is having acne, she is having hirsutism, she is having irregular periods. Very good, and therefore the diagnosis is most likely to be PCOS. So PCOS, we know, Hitesh Singhe, not B, not D. Please, I wanted to tell you this. B and D is for ovulation induction when she is having infertility. Here she wants treatment for acne. Will clomiphene or letrozole decrease the acne? No. Will this? No. OC pills with cyproteron. Cyproteron is a what is cyproteron? So please understand this. When you have PCOS, if they tell you patient is having infertility, patient of PCOS, not IVF पे time पे, no, IVF के time पे नहीं बेटा, IVF, all PCOS don't require IVF. Okay, IVF के time पे we use all HMG and recon. Okay, so PCOS, when they tell you that the patient wants babies or she is suffering from infertility, then you have to go for ovulation induction, and that is the time when now today letrozole, remember letrozole is the first drug of choice. Remember this, again a very important MCQ. Will tell you patient is saying that there is infertility in PCOS, then give for letrozole first, clomiphene citrate second. But when she says, doctor, I am not planning babies, my concern is acne, hirsutism and irregular periods, then you please give her OC pills. Okay, clap if you feel happy. नाम में ही आंसर है PCO, उल्टा कर दो OC pill. Those who are hearing me for the first time. Okay, PCO, OCP. Okay, PCO, polycystic ovary, just inverted oral contraceptive pill. Okay, PCO read ulta, be OC pill. So here you give OC pills to the patient, and which OC pills will be preferred? So the one which has got cyproteron or drosperinone containing OC pill is better, because they have got anti-androgenic property. Common sense, we want to treat acne, we want to treat hirsutism, so I need to suppress the androgens. I need something which is going to have anti-androgens. Okay, so please, for God's sake, this is very important, student. Do not invert the treatment. You cannot say, okay sir, infertility patient, I will give OC pills. Similarly, young girl with acne hirsutism, please don't give letrozole and clomiphene. Inversion of the, you cannot cross the treatment. Is this understood to all of you? So that is wrong. Okay, is this clear to all of you? Yes. Yes, this was again asked, very simple MCQ. What would be the first sign in a patient of magnesium sulfate toxicity? The magnesium sulfate toxicity, what would be the earliest thing is, we monitor knee jerks, respiratory urine output, we have to loss of knee jerks. Loss of knee jerks is the first thing which happens. Then the respiratory depression, cardiac arrest, all that happens later. And what is the antidote of magnesium sulfate toxicity? Also we should know, calcium gluconate. Calcium gluconate is the drug of choice for magnesium sulfate toxicity. Okay, yes dear students, this is what it is. All those who are marking this, okay, webbed neck, shield shaped chest, widely spaced nipples and streak ovaries. What is this now? Yes sir, this is Turner's syndrome. By the way, if I do ultrasonography, yes, it will be streak ovaries, but uterus will be present. Uterus is present. Okay, a small hypoplastic underdeveloped uterus is present, but it is not absent. So remember, Turner's syndrome, uterus not absent. Is this clear to all of you? Yes, of course, the karyotyping 45XO. Let us revise again this also. RMKH is 46XX. It is XX. And androgen insensitivity is 46XY. It is testicular feminization. So it's actually a boy. There are testes. Okay, so keep all these points in mind when you are giving the MCQ. Which of the following is not present in abruption? Abruption, students, is a condition where it's antepartum hemorrhage, is pain, bleeding, uterine tenderness is there, PPH can happen, pain is there. Painless vaginal bleeding is seen with placenta previa. Okay, painless vaginal bleeding is seen with placenta previa. Abruption pain will always be there. Okay, yes, somebody was asking me this, that which of the following can be used for up to 5 days of emergency contraception except, okay, so somebody, yes, abruption pain. So IUCD can be used up to 5 days. Ulipristal 30 milligram single dose is very new. It's something very new which can also go up to 5 days. And this LNG 1.5 milligram, brand name we are not, but this is your popular I pill. And why this is the answer? Sir, I pill is only up to 72 hours. Okay, only up to 72 hours is what you give. So LNG 1.5 milligram single tablet. Somebody asked me, it is up to 3 days for emergency contraception. Okay, and we will have one time for this MCQ. Yes, which of the following has got the worst prognosis when you look at heart disease in pregnancy? Heart disease in pregnancy, remember, ASD, VSD, PDA easily tolerated, mitral stenosis slightly more danger, aortic stenosis more danger, but Eisenmenger is your reversal of shunt. Okay, reversal of shunt, or basically secondary pulmonary hypertension. So both primary pulmonary hypertension, secondary pulmonary hypertension, and if there is Marfan syndrome with aortic, has got the worst prognosis. And the last question, yes, so this has got the worst prognosis please keep in mind. Okay, Eisenmenger syndrome or pulmonary hypertension. And we will do this very important. Which of the following is indication of surgical management for ectopic pregnancy? So in ectopic pregnancy, always wherever possible, we try to give methotrexate as the treatment of choice. But for methotrexate, when I want to give, the patient should be stable, of course. Then only I can give methotrexate. The cardiac activity should also be absent. And what is the criteria for gestational sac for methotrexate? So gestational sac should be less than 4 centimeter. So I repeat, if the patient is stable, the gestational sac is less than 4 centimeter, and of course the HCG levels should be less than 5000 micro international units per ml. So if anything is not satisfied, that means, sir, if I have a sac, of course if it's a shock, if the patient is in shock, I need to go for immediate surgery. If the sac is more than 4 to 5 centimeter and if the HCG levels are more than 5000, so this is the answer, beta HCG levels of 7000. Is this understood to all of you? Beta HCG 7000 is a clear indication for surgery. Methotrexate cannot be given. Okay, and the last and the simplest MCQ, the congenital anomaly specifically associated. Specific, VSD is the most common, followed by neural tube defect, but the most specific anomaly is which one? It is your caudal regression syndrome. Caudal regression syndrome, also called as sacral agenesis. Okay, so please share this video with all your friends. Best of luck, wishing you all the best for the upcoming exam. Also, you can go and see 2-3 days back I put a video, last 15 days how to do the revision. Okay, and I wish all of you best of luck. Don't worry, if you have seen my lectures on vitals and otherwise this also, you will surely pass FMG, is my guarantee. 35 to 40 MCQs come from my lecture every year, is a guarantee. You will remember me on the day of the exam. This 2.5 hours marathon, please send the video to all your friends, let them see those who missed it, and I'm sure you will definitely, yes, आशीर्वाद बेटा हमेशा आपके साथ है. Please do very well, read the question correctly, no panic, no stress, and definitely just paper will be definitely simple. OBGYN will be very easy. Wishing you all the best, and all of you will do very well, is my guarantee. Don't panic, don't stress, and regularly attend the classes. Your performance will improve. Wishing you best of luck. 35-40 questions OBGYN se come from this only. Many questions will come. You come back and let me know how much. Okay, thank you. Yes, okay, best of luck, and I will see you in the upcoming classes. Bye bye.